So we're back at it. Here we are. This is lecture number 14. This is the advanced knee. This is the second part of two parts on the knee. Last lecture we discussed basically the muscles surrounding the knee from the hip down to the ankle, actually everything in between that controls or crosses that knee joint. And so today we'll take a look at our pieces that have a little bit more to do with our perineural protocols and then our regional diagnosis specific protocols. So we'll just move right into that. I'm going to minimize my picture there. All right. So as always, whenever we're dealing with a patient subject, what we want to do is perform a functional movement screen, or what I call a 3D kinetic screen. A lot of different ways of doing this out there. I like the one that I've developed. Others are geared more towards an athletic population, and nothing wrong with that in your athletes. But this one is a little bit more functional for our everyday person that we'll be seeing coming into the clinic. It can still capture movement abnormalities with our sport athlete population, but also is appropriate for, again, that 70-year-old person that's got some issues going on. So a little bit more encompassing for the population as a whole, I feel. So we will, I'm not going to play the kinetic screen. You've seen it multiple times before. We'll probably look at it again one more time next lecture when we go over everything with the ankle and foot. But I will tell you in advance, one of the pieces of homework similar to with a hip will be to find a subject that you can have perform a 3D kinetic screen on, and then make your best judgment on what you think you would need to needle on this particular candidate. So bear that in mind as we get towards the end of the lecture here. So let's start basically, excuse me, with our perineural protocols. We have a novel genicular protocol that I developed using the anesthesiologist injection points for anesthesia around the knee. So we'll look at that first. Then we'll look at, some of these we'll have already looked at in the hip. We'll look at lateral femoralcutaneous nerve, the muscular branches of the femoral nerve, posterior femoralcutaneous nerve, lateral surlcutaneous nerve, the saphenous nerve and its medial percutaneous nerve, then the medial surlcutaneous nerve. So let's jump straight into the genicular protocol. Here we're definitely dealing with 6 different nerves around the knee that provide sensory innervation to that area or input to the brain about the function of the knee joint. Usually genicular protocol is not my first option. I may look at some general muscle issues, some inflammation, but for the genicular protocol, I do want to target directly all of the nerves involved. The nerves are the middle genicular, the superior lateral genicular, the inferior lateral genicular, and the recurrent fibular nerve. So on the lateral aspect, we have 4 needle locations. And on the medial aspect, we have the superior medial genicular nerve and then the inferior medial genicular nerve. And we'll go over the specific locations momentarily. These arrive either from branches of the tibial nerve. For the tibial nerve, we see the superior medial, excuse me, genicular nerve, the middle genicular, and the inferior genicular. Then coming off the common perineal nerve, we'll see the superior lateral genicular nerve, the inferior lateral genicular nerve, and then the recurrent genicular nerve. So we're really dealing with 2 different nerve groups here. Getting straight into it. The superior medial genicular nerve, it's going to be on the medial aspect of the knee. We're going to palpate with the adductor tubercle, and it's going to be basically 2 finger breadths superior to the medial joint line. The superior medial genicular nerve, it sits just superior to the condylar ridge, so the needle location will be medial to lateral, the midpoint of the femur, and we're going to use the femur as a backdrop, placing the needle just superior to the superior medial genicular nerve. Inferior was going to end up being, we'll palpate for the space between the two ligaments or tendons of the pes anserine, excuse me, and we're going to be 1 finger breadth distal to the medial tibiofemoral joint line. Needle angulation here will be medial to lateral with the tibia as our backdrop. And actually, it is the same location as the pes anserine bursa. So we on the medial aspect, we have adductor tubercle, then we have the pes anserine bursa. We move laterally. Our very first needle location for the superior lateral genicular nerve will be 1 finger breadth superior and lateral to the superolateral patellar pole, the needle point directed medially and posteriorly 45 degrees with the femur as a backdrop. There's a thick fibrous sheath directly beneath this location, so definitely need a little bit extra force to push that needle through to get down to the femur as our backdrop. We're going to move 4 to 5 finger breadths superior to that, from that superolateral pole of the patella. And here we're going to look at going almost lateral to medial, coming superior to the IT band as it's coming across or traveling distally towards its insertion on Gerdy's tubercle. And so here our idea is that we want to insert our needle here, run it across the frontal plane to land just superior, or I'm sorry, anterior to the femur for the medial genicular nerve. We'll drop a little bit for the recurrent perineal nerve. Here we're going to palpate for Gerdy's tubercle, which is the attachment site of the IT band. Needle placement is going to be between the anterior tib margin and the patellar ligament, and an anterior to posterior angulation with the tibia as a backdrop. So we can either palpate for Gerdy's tubercle. Some people it's easy to palpate, other people it is not. If we use different landmarks, find this medial most border of anterior tib, and then the patellar ligament, and the midpoint there will be our needle placement site. And finally, for the inferior lateral genicular nerve, basically it's going to be middle joint line on the lateral or fibular collateral ligament. And so we've got our 4 locations in on the lateral aspect, 2 on the medial aspect. When we talk about our electrical stimulation on this, I typically will recommend first session, keep it at a single low frequency stimulation for up to 20 minutes. As long as that's tolerated well and we see some improvement in pain, then we may want to switch to a biphasic frequency with a short period of, say, around 3 seconds of a low frequency around 3 hertz up to 75 as high as 100 hertz for an additional 3 seconds. We'll just alternate that back and forth to prevent any sort of neural accommodation. All right, so let's jump and let's look at this here. So let me bring my library back. All right. So for the genicular protocol, so all the muscles have been removed in this particular place. Here's the fibula. Here's our lateral aspect. Rotate in. Here we are on the medial. So our first is going to be at the adductor tubercle, located right here. Our second on the medial aspect is going to be at the pes anserine bursa, which sits at the MCL about a finger breadth distal from that medial joint line. Next, we're going to come to, on the lateral aspect, we're going to take this superior lateral pole of the patella. We're going to come up 1 finger breadth more cranially, and then 1 finger breadth laterally. Okay, then our more superior to that, 4 to 5 finger breadths from this same superior lateral pole of the patella. This is the one where we're going to come from the lateral aspect. We're going to be just anterior to the IT band, and we're going to needle in a frontal plane across that muscle, that thigh, to land just anterior to the femur. Okay, we're going to come down and we're going to find Gerdy's tubercle. Again, this is where the IT band continues down to attach at this location. But we could also use our other landmarks, the patellar ligament as a medial border, and then the medial border of the anterior tib. And in that window between those two places is where we'll drop our other needle, again, using the tibia as our backdrop. And then lastly, in the joint line, the lateral joint line, on the lateral collateral ligament itself, we'll just drop needle through that ligament to get our sixth needle placement. Very frequently, there's going to be some other things going on with this. If we've got some noted inflammation in, say, the patellar tendon, if we've got, I see most commonly, we'll see a little bit more of some problems with the pes anserine itself, maybe with the medial hamstring group, and with the proximal calves. Those tend to be involved as well. So we may find, in addition to the 6 needles for Genicular Protocol, that we add some other symptomatic treatment as well. But again, frequency, first treatment, I'll always go with a low frequency for up to 20 minutes. And then on subsequent treatments, as long as tolerated and good result from that, I might switch over to a biphasic low frequency to a high frequency, and just let that alternate 3 to 5 seconds each direction. Okay. Next will be our protocol for the lateral femoral cutaneous nerve. We addressed this in the hip, but we'll look through this again. Again, it's indicated by our sensory input from the lateral aspect of the thigh for our treatment. Let me come back. Our primary locations is going to be 1 finger breadth medial from the sartorius, distal to the inguinal ligament, will be anterior to the TFL at the junction of the rec fem. Will also be at vastus lateralis rec fem junction mid-thigh, and then at the IT band vastus lateralis junction mid-thigh. Here, and then at the VL vastus lateralis rec fem junction, 4 finger breadths superior to the pole of patella. So basically, we're just going to follow this nerve down its course as it's where it comes out below the inguinal ligament, and then further as it's following its course in between rec fem and vastus lateralis. We can also address that at L2 and L3 if we want to deal at our spinal segmental locations, being supplied to the lateral femoral cutaneous nerve. We'll look at that here. And so we'll see that as that. So let's kind of zoom in here, out of the way. Let's highlight here in pink is our lateral femoral cutaneous nerve. A common area of entrapment is that nerve exits underneath or beneath the inguinal ligament on top or anterior to sartorius. That is an area that it can become entrapped, but will then continue to follow that down here anterior to TFL between that and rec fem. We'll catch 2 locations, one at the junction of mid thigh of TFL or the IT band into vastus lateralis. If you recall, that's one of the prime locations where we'll actually needle for vastus lateralis there. But in addition, we'll also move over to the junction between vastus lateralis and rec fem as a needle location, and then further 4 to 5 finger breadths proximal to superlateral pole of the patella, in between, again, VL and rec fem, needle placement there. So that is our lateral femoral cutaneous nerve. Let's come back now. For our muscular branches of the femoral nerve, we looked at this as well, dealing with the hip. And this thing tries to run away with me. So we'll look first at mid-thigh, the junction of vastus medialis and rec fem. So here's rec fem sitting right here. We're going to move a little bit further over into where, and it's hidden in this picture. We'll look at it in 3D in just a second, but we'll get at that junction mid-thigh between vastus medialis and rec fem. We'll go ahead and hit at mid-thigh at rec fem as well. We'll go through rec fem down through vastus intermedius if we were kneeling that deep, but these will be superficial, so 1.5 centimeters is all we need to look at. We'll drop down to the mid belly of the bulk of the VMO, so that muscular needle spot that we have for VMO further distally. Again, we're going to be superficial, so that can be as shallow as 1.5 centimeters. And then we'll find a midpoint between those two needle locations there. So let's jump back here. It's here. Okay. So again, let's highlight that nerve. So femoral nerve, these are just the muscular branches. So this is probably less to do with pain, more for motor control, trying to get some activation of the quads, so to speak. So here, again, here's this area between, and actually it'll be through sartorius as well, but the junction between vastus medialis and rec fem will be our first needle location. We're going to use that reference. We're going to move further to our traditional needle location for rec fem, right here, or vastus intermedius. Again, these will be superficial, so just 1.5 centimeters is adequate in depth. We'll take our traditional VMO, vastus medialis needle location, one needle there, and then between our first needle point and that point, we'll find a midpoint and drop needle right there. And again, 1.5 centimeters for that. Again, this is a good approach if you want to help facilitate some muscle response, neuromuscular firing. That's a good protocol for that. Okay, we'll come back. Okay. The posterior femoralcutaneous nerve. Again, this posterior thigh piece, as far as our sensory, down to a little past the popliteal crease there. Again, we looked at this when we dealt with the thigh, but this first needle location is going to be junction of the medial and lateral hamstrings at the inferior aspect of gluteus maximus, so just right below the fold, in between those two hamstring groups there. We'll also do it at the bifurcation of the distal hamstring. So whenever we're needling our medial and lateral hamstring group, we draw our femoral, our danger zone, if you will. So here we're going to do that again. We're going to come up just a little bit above that for our distal hamstring point. And then we're going to split those 2 points, and we're going to put one right in the middle. So basically, we're just following the course of this posterior femoralcutaneous nerve as it dives down between the medial and lateral hamstring group, just avoiding to stay away from our popliteal fossa here. And so that's what we look like. Again, so if we choose, we can go up S1, S2, S3. If we're having trouble getting a response here, they're going to be prone already. So easy to get into that sacral area to address that. All right, let's jump. Where do we go? There we go. Again, let me come in and highlight that nerve. Again, I keep mentioning this. All of the 3D anatomy software that we use is from Complete Anatomy, provided by Elsevier Group. Have author permissions to use that, and it's one of my favorite programs that I've used. I've used quite a few different ones, but I really like this one. So again, not to promote it, but this is the one that I use for study, for diving into your anatomy. Definitely a valuable piece of software to have. So anyway, here we are. We see this right below the gluteus maximus, where the medial lateral hamstrings are coming together here. we're going to place our first needle there. Our second will be at the further distal bifurcation of the hamstrings, further distally. And then we're going to take that mid spot in between those. Again, following that nerve as it courses through the medial lateral piece of the hamstring. Superficial in nature, 1.5 centimeters is as far as we need to delve with there. All right. Share again here. Okay. The lateral surlcutaneous nerve. This is a nerve that I've actually personally had issues with, some entrapment. And so the protocol here definitely was something that I developed to deal with my own symptoms. And it was very effective in managing that. The lateral surlcutaneous reflected here in blue, but it's also part of the yellow as well, coming on down, all part of the perineal nerve. So let's dive into that. Let's see here. So for lateral surlcutaneous, our primary neural location first is going to be posterior to the bicep femoris at the lateral femoral condyle. And we'll get to all the specifics when we get to the 3D anatomy. Then will be 4 finger breadths distal from the fibular head into the peroneus longus. Will be a distal into the distal third of the peroneus longus. And then finally, if we choose, we can go into spinal segmental locations, L5, S1, and S2. So let's go look now at that here. Close, and let's bring this right back up. Okay. So as you can see, the lateral surlcutaneous nerve covers a lot of area, but it does come off of the common perineal nerve right behind the tendon of biceps femoris. So our first needle location will be just lateral to medial into this area. Again, superficial, we can use 1.5 centimeters. No more than 3 centimeters is necessary there. We'll come on down and into about 4 finger breadths distal from the fibular head. We'll drop into a peroneus longus. We're going to drop even further into the distal third of that peroneus longus, actually anywhere along that path in the distal half of the half or third of the peroneus longus. I want to drop a needle in there again, simply so we can get several locations to provide some stimulation for that nerve. So curious, my personal situation was I was having the pain, the altered sensation out into the lateral aspect of the foot. I noticed it primarily whenever I was take a shower and I would dry my leg. If I were to dry my leg pushing the towel down, I had no sensation problems at all. If I dried pulling the towel up, significant sharp burning pain in that. And so in my case, that probably lasted 6-8 months. I dry needled it several times, got a little bit of relief. In addition, I added on top of that some instrument assisted soft tissue mobilization as well. Like I said, dry needling is never the only thing that we need to do. We need to look at other treatment options as well. This is just a great tool. But this is the approach that I took with mine. And after about a week, those symptoms subsided, went away, and have not had any recurrence with that, say for the past, that was a couple of years ago. Have not had recurrence since then. Traditionally, our area of entrapment is going to be right behind the bicep femoris tendon. In my case, my entrapment was a little bit more out in this area, more in the lateral aspect of the thigh, of the calf. So that's good protocol, lateral surlcutaneous nerve. Okay, so we're continuing on. So the saphenous and medial cutaneous nerve. So here we see on this medial aspect, distal to the knee joint line itself, is where we see our sensory piece for that. Saphenous, I'm not going to read everything about the saphenous nerve, but you can see a long course it takes coming down And so here can experience entrapment from exercises involving the quads or from prolonged walking or standing, characterized by a burning sensation in most patients. Most patients in pain often occurs at night, long after physical exercise, which induced it has stopped. Can also be aggravated by climbing stairs. Here, our needle location is going to be at me again out of the way, at the medial joint line, at the pes tendons, at the mid-medial tibial shaft. So we'll look at this in our 3D anatomy as that nerve courses across the surface of the tibia. That's going to be a superficial, a tangential type needle placement. And then lastly, at the anterior aspect of the medial malleolus. Then we can always look at our proximal spinal segmental locations, L2, 3, and 4. So let's go now and take a look what we've got here. All right, so bring the library back. Where did we go? Here we go. Okay. One moment. Had some technical issues today. See if we can get those squared. Okay, so move that back out of the way. So for our medial surlcutaneous, is a distal to the saphenous nerve. And number one, the medial joint line. We needle a lot of stuff right here. You can see just distal to that. Below the joint line is our pes anserine bursa. But here we'll just stay medial joint line through medial to lateral. Again, about 1.5 centimeters is as far as we need to go. In the mid portion of the tibial shaft to needle this. Our needle placement will be, we can either take a direct approach onto the tibia itself. For most people, that is very superficial and hard to keep that needle in place. And so I'd recommend coming across, palpating down the tibial shaft, and then needling from medial to lateral, just parallel or on a tangent to that tibial shaft. So basically threading across the tibia. And then lastly, we can come down just anterior to the medial malleolus here. Again, 1.5 centimeters is the bulk of the depth that we need, and can stimulate that for up to 20 minutes on an initial treatment of 3 hertz, progressing to a biphasic low to high frequency treatment approach. Okay, now let's come back. Let's look at our medial surlcutaneous. I did not update this picture. This is iliohypogastric. It is not the medial surlcutaneous nerve, but the rest of it will be about medial surlcutaneous. So here we see, so similar to how we had the posterior femoralcutaneous bisecting the muscles of the hamstring. Here we're going to see it bisecting the 2 heads of the gastroc. And so basically, come to our discussion here. We'll be at the bifurcation, me out of the way, there we go. We'll be at the bifurcation of the 2 heads of the proximal gastrocnemius here, just at that distal aspect of that inferior femoral triangle. Again, we're going to be superficial, 1.5 centimeters. So we're staying away from the vascular bundle there. We'll come on down to the musculotendinous junction of the Achilles tendon in midline, and then we'll find a midpoint between there, and that will give us our locations for the medial surlcutaneous. Likewise, we will look at proximal spinal segmental locations if necessary, L5, S1, S2. And let's come take a look here. Okay, my brain drifted there momentarily. All right, let's come back and share. library back. Okay. So again, we see the bifurcation of the two heads of the gastrocnemius at the popliteal crease. You remember we made our popliteal line. We drew our superior triangle. We have a similar inferior triangle. So at that bifurcation, we'll drop needle number 1. We'll drop further into the musculotendinous junction here of the gastroc into the Achilles. We'll drop another in midline there, and we're simply going to take a midpoint between those two needle locations for our third needle location. Again, superficial 1.5 up to 2 centimeters in depth is all we need to deal with there. Okay. And we just did medial Surlcutaneous. Now let's move on to our regional or diagnosis protocol. So quite a few things that we look at here. You will see that there's some carryover between different needle placements for the different problems that we'll deal with. But there's a lot of tendons, a lot of ligaments in and around the knee, a lot of bursa. And so these are basically a lot of the things that we'll see clinically. And so a few other things that we won't see that often, but some innovative, some novel treatment approaches using dry needling for these. So very first thing, we'll start with a hamstring strain. So here, it's an article talking about hamstring strain. What we'll see with this is, slow down. So we have some issues where we can deal with the hamstring more proximally, and we talked about that a little bit when we did it through the hip. But here, our primary locations is going to be bicep femoris, and then semimembranosus and tendinosus for our primary locations. Here, we're dealing with those more distally. When we're dealing with, that's with a distal hamstring strain. If it's more of a proximal strain, then here we would look at the sciatic bursa of gluteus maximus, then the hamstring tendons themselves. So when we went through our ligaments and tendons of the hip, we talked about the needling protocol for that. So we had reference back to that approach for the tendons of the hamstrings. Always, if we can identify if that strain is more mid-belly, which it's more frequently mid-belly, then we can definitely move our needle locations from the distal aspect up to mid-belly of the hamstrings. Needle those right there and get that response that we're looking for. Finally, we can look at our sacrotuberous ligaments and quadratus femoris. So the sacrotuberous ligaments, anywhere from ischial tuberosity over to the sacropoccygeal junction, then up to the PSIS to give us those 3 potential locations for sacrotuberous. And then quadratus femoris on our pelvic rotator cuff group. This was our terminal needle placement for that 3 to 4 needle redirection angle. Again, sits between ischial tuberosity and the lateral apex of the greater trochanter. Let's see if I've got the hamstring strain here. Let's bear with me here. Let's see if we've got hamstring strain. I think that's 12. If I can spell. Here we are. Okay, so for our hamstring strain, and what we're looking at is if it's a more distal strain, we'll take our 2 needle locations through the lateral medial hamstring groups themselves. If it's a mid-belly, then we simply just move these needle placements into the middle of the posterior aspect of the thigh. As long as we stay away from midline and angle our needles away from midline, then we have no problems. We can needle anywhere along that path. But if it's more proximal strain, then what we'd want to look at first is taking this needle from lateral, from medial to lateral, keeping in mind sciatic nerve is laying right here. We can use that to needle those tendons there. There's all three of semimembranosus tendinosus and bicep femoris there. So we'd hit those there. We could also drop down a little bit into the more proximal, the muscular fibers as opposed to the tendinous. If we're dealing with the hamstring strain, odds are we're going to be dealing with this wonderful little structure, sciatic bursa, gluteus maximus. There are times, lots of times, where all you need to do, patients are only going to respond by needling directly onto that. So that's just some pecking down to that. Sacrotuberous ligament is represented here, so we can catch that on the ischial tuberosity, again, at the sacrococcygeal junction or the slightly inferior to the PSIS. And then lastly, we could include quadratus femoris as well. So any of these pieces that are involved in the origin or the insertion of the hamstring, definitely somewhere along this muscular fiber, we'll definitely need to needle into that. But more often, especially more proximal, we're going to see some of this other involved as well. So always a good idea. Maybe not the first time, second needle session may come back and to look at these. Okay, for quad tendonitis. So quad tendonitis is simply strain of the quadriceps tendon there as it attaches onto the patella. Here, our primary location. If that's happening, that means there is a load in the quad. So we definitely want to, number one, primary locations, hip, rec, fem, vastus, intermedius, lateralis, and medialis. So take that load off of the tendon itself. After that, we want to come in. We want to go ahead and needle into the quad tendon itself. So for that that tendon, because we have pieces coming from the lateralis and the medialis, we'll do one right in the middle, just proximal to the drop off of the patella, and then we'll do a little bit lateral and a little bit medial as well. We'll want to do the suprapatella bursa as well. And then we'll look at the subcutaneous bursa here, the prepatellar bursa, and then infrapatellar bursa and midline here. And then lastly, the patellar ligament. Honestly, you'd needle one of these, infrapatellar bursa or patellar ligament, that will cover what we need there. So let's go back now to library. Where are we? I'm not seeing this here. All right, let me filter this again. I don't think that changed much. Right, it was there as well. Okay. What was that? So again, number one, we want to take care of any muscle load, muscle tension sitting in the quads. We'll take our rec fem, our vastus intermedialis and rec fem point, vastus lateralis, and then for the VMO further distally. We'll take what we're looking for our our quad 10, actually here, our suprapatellar bursa, which is going to sit very deep. Can't really see it right there. But then 3 locations, quite just slightly proximal to the bony drop off of the patella into the quadricep tendon itself. And then we have infrapatellar bursa, subcutaneous bursa, and then the patellar ligament itself. So for quad tendonitis, we deal with the quad, and then we deal with all of the linear connective tissue, quad tendon, patellar ligament, and the subsequent related bursa as well. For patellar tendonitis, again, very similar response that we did for quad tendonitis. Primary location, we're going to hit the patellar tendon. Patellar tendon can be a secondary issue, can have be more related to movement or stance issues. And so we hit the patellar tendon first in this approach. Our second will hit the quad. So obviously there's probably going to be a quad load. So we'll go ahead and hit, again, rec fem, vastus intermedialis, lateralis, and intermedius, lateralis, and medialis. We'll drop down again. We'll hit the subcutaneous infrapatellar bursa and the deep infrapatellar bursa. So very similar to what we were doing before. We just didn't identify in our assessment that there was any response in the quad. It's the quad tendon itself, so we leave that piece off. If you happen to sense an equal amount of inflammation in the quad tendon and the patellar ligament, then you may want to go ahead and combine these two together, which basically would just involve adding needling for the suprapatellar bursa and the quad tendon itself. And so we've already talked about that, so I'm not going to bring that picture back up. And so now for the excuse me, the bursitis, supra, subcutaneous, and then infrapatellar bursa. Frequently, we see that some of these bursa actually have communication. It doesn't necessarily have to be a single unit. But whenever we deal with bursitis, basically this fluid-filled sac gets inflamed, it swells, and we want to elicit an inflammatory response to get that thing back to normal movement or normal function. So for patellar bursitis, first, we're going to hit the suprapatellar bursa. We're going to come down in the subcutaneous prepatellar bursa, the subcutaneous infrapatellar bursa, and then deep to that is the deep infrapatellar bursa. So we can hit these 1, 2, 3 needles to get all of those. The subcutaneous prepatellar bursa, probably not as involved as the others, but if there's a site of inflammation there, we can go ahead and needle that. Secondarily, again, we're going to unload the quad. We need to decrease whatever the load is that's creating that inflammation. If it's acute, it very well could be from a contact issue, but if it moves to subacute or more of a chronic situation, that quad is definitely going to play a role, and we cannot get rid of that inflammatory process unless we deal with what's keeping it inflamed. So our tertiary location would be, again, both the quad tendon here and then the patellar ligament. So again, no, it's here. Well, I've placed this somewhere. Okay, so I can't find it. Let's just pull any of this up. What shall we do? Let's just pull this up. So again, for bursitis, we want to catch our deep suprapatellar bursa. It's going to be hard to view under all of this, but we're just going to come a couple finger breadths proximal from the superior patellar pole. We want to hit this subcutaneous prepatellar bursa, and then the infrapatellar, and then the deep infrapatellar, which is hidden right there, but it's behind the patellar ligament itself. After that, we want to hit the quads themselves with our needle, decrease that load. And then if we're still dealing, we want to hit the quad tendon up here, and then the patellar ligament further distally. Okay. For knee osteoarthritis, and here we're more dealing with the femorotibial arthritis as opposed to patellofemoral. This is our older person who's got some stuff going on. So let's take a look here. So knee osteoarthritis typically involves both the medial lateral and the patellofemoral joint. I'm going to pull the patellofemoral joint out because we'll deal with that with a little different approach. So here are primary locations. Our sartorius, gracilis, semitendinosus, and the pes anserine tendons. So that medial group there. We will secondary look at the pes anserine bursa, the adductor longus and adductor magnus, and then the quads themselves. And then finally, if we're not getting the response we want to get out of dealing with the muscle load itself, we'll drop in and we'll throw the genicular protocol on top. Normally we deal with this knee OA, we hit this medial aspect of the knee, and that is normally what we need to see. So again, there are our placements. Let's go ahead and see if I can manage to locate this now. You know, let's look here. Okay, well, it just doesn't seem to want me to look at that one. Let's filter it this way. No, this isn't the one, but we're going to use this as our example, even though we don't have the spots on here. So number one, again, it's almost always related to this with knee OA, this medial group. So we're going to see a lot of pain and tenderness through the three muscles of our pes. So I will come in, I'll needle through the ligaments, the attaching tendons themselves. And then my approach is I will needle through adductor magnus and longus as well on this medial side. I'll just take a sky side to mat side, anterior to posterior needle approach. As I do that, I'm also going to needle through my sartorius, my gracilis, and the adductor magnus as well. Longus is going to kind of fade off midway. I definitely, if I'm dealing with knee issues, I definitely want to come in and needle in to get, again, reduce the load of the quads. And then we can look more at some more structures. But as far as the generalized knee OA, we want to hit this medial group first through the pes. We'll talk about pes in just a moment. Through the tendons, onto the bursa itself. We'll needle about in this area through sartorius, gracilis, adductor magnus, and then we'll come back and hit the quads. Okay, now the pes anserine bursitis. Again, tendinous insertions of sartorius, gracilis, semitendinosus, called the goose's foot. It can be from a lot of different problems. I tend to see it more related to knee degeneration, osteoarthritis. It could be a varus valgus problem, but almost always we see this in that older or heavier population. For that, we're going to needle sartorius, gracilis, semitendinosus. We can go over into sideline, isolate those three, and needle directly into those. We definitely want to do that. Then we want to hit and land into the pes anserine bursa. We'll look at that right here. Let's see if I've remembered to do this correctly. And I don't have it isolated there. So let's come back. Which one? Let's just pull this up. All right, I'm going to get rid of those because that's not what we're on. Get me out of the way. All right, get rid of those things. Okay. So number one, definitely we want to come in and needle. Let me actually, since I've got this, bring in my tools. Let's do that. Okay. We want to hit our sartorius. So we'll just be in sideline here. It's the easiest way to get to this. Sartorius, gracilis, semitendinosus as they come down. We're also going to want, close that, to come in and needle a couple of ways here. Let me zoom in just a little bit. Let me grab this back. So we talked about earlier, last lecture, lecture 13, about needling through the pes tendons. So basically, I will run, and I'm going to make this into a 2D. I will find my tibial crest, and I'm going to needle along that crest this way. I just want to thread through those tendons right there at their insertion point. There will be a piece of some tightness or some pain and inflammation there. More specifically, we also want to end up on, so let me close that. Our pes bursa itself, let me highlight that, sits right there. It sits superficial to the medial collateral ligament, but deep to semitendinosus. And so it's on the, if we take that medial collateral ligament and we drop about a finger breadth distal to that joint line, that will give us our needle placement for our pes anserine bursa, just right there. So I will always take a thread approach for the tendons across there. I will needle directly onto the pes anserine bursa itself, and then I'll try to isolate each of the muscles individually, a little bit more, maybe a palm breadth more proximally, into sartorius, gracilis, and semitendinosus. All right. For a Baker's cyst is simply a situation where that posterior capsule extends, maybe there's a herniation there, and it extends that capsule with a fluid buildup. The biggest thing that we can do to help with that is reduce any load, any muscle tension in and around the tissue surrounding that. So obviously, it's going to exit in this popliteal fossa. And so we've got plantaris, we've got the gastroc in here. We've also got the hamstring. So our primary locations are going to be the semimembranosus, the biceps femoris, then the medial and lateral head of the gastroc. Secondary, we're going to come in and we're going to catch our plantaris. We talked about how to do that in the previous lecture, actually in the introductory lecture. And then we'll come in and we'll look at the oblique popliteal ligament and the arcuate popliteal ligament, which we addressed last lecture. So that should have that here. We'll keep our fingers crossed. Oh, goodness. Well, we're just going to go back to how we had been doing this. Here we come. That's disappointing. Okay. We'll take our meniscus example again. So here, let me close that out. So for Baker cyst, we'll catch approximately the semitendinosus, specifically semimembranosus, as it's coming down. I'll go ahead and catch bicep femoris. Again, that joint line is going to be distal to that, but they do cross that joint line. So let's unload those muscles as well. Definitely gastroc plays a role. So we want to go ahead and needle those. The gastroc, we can come down mid-belly, basically at the distal aspect, anywhere distal to that popliteal inferior V that we created. After we do that, then we want to come look at the arcuate and the popliteal ligaments, because they do get very close there and have a fairly strong function there at that posterior aspect of the knee. Lastly, we can also come in and catch plantaris. Again, so the whole idea is to decrease the general inflammation around in that area. I don't think that needling into the Baker cyst itself is going to cause anything productive. But if we can decrease the tension, the load on those things around it, that may provide a little bit of some pain relief and decrease that load, that compressive load that's creating that in the first place. Okay. For an MCL, medial collateral ligament or tibial collateral ligament strain, our primary location, we're going to be at MCL itself. Then we're going to look at the pes and serine tendons because they are so contiguous to that area. Those will be our primary first locations. People ask me, well, do you actually needle into the ligament? Well, absolutely. It's that ligament that's inflamed and giving us our pain on palpation. So let's needle that thing. Our secondary locations, again, we'll look then at the pes and serine bursa, but that also sits on that or superficial to the medial collateral ligament. And let's go ahead and catch vastus medialis as well. That plays a key role in the power production on the medial side of that knee. So let's hit that. Then finally, adductor longus and magnus, specifically magnus, as it's coming down and has its attachment there or insertion onto the adductor tubercle. So let's see now. I'm going to try one more time. No. Well, let's pull the meniscus out. We're going to come back to this anyway. So let me get rid of that. Okay. So definitely if we're needling, if we're treating the MCL, we want to find that MCL. Easiest thing is to catch it right in the middle joint line. We know we're also going to, because all the pes tendons are right, and muscles and tendons are right here, we're going to needle through those. Definitely want to do that. And likewise, we're going to hit the pes bursa. Again, like I mentioned previously, we're going to see a lot of carryover, a lot of overlapping of things that we treat around here, around the knee, because it is so dynamic of a joint. So we'll needle the bursa, the MCL itself, the tendons of sartorius, gracilis, semitendinosus. Will also, as it comes down, so you can peek through here, there is adductor magnus. Any of those can contribute to pain, whether it's actually the MCL or if it's just generalized. We needle adductor magnus as well. It can be needled here or in our traditional approach in that sideline position more proximally. So MCL. We'll get to the lateral collateral ligament as well. And since I'm here, part of what we'll needle is, again, the ligament itself. When I'm needling this, I'll probably also want to look at associated things around it. So here comes the IT band towards Gerdy's tubercle. We also have bicep femoris coming very closely. There is a bursa that sits just distal or deep to that is the inferior subtendinous bursa, bicep femoris. So when we needle into our middle joint, our mid-joint line, we can get all three of those all at one time. Because of their proximity, we could also look at the peroneus longus, extensor digitorum longus, and tibia anterior as potential needle sites, as well as the lateral head of the gastroc, and even, bring it up, soleus, because it's very close there. Again, we could look because of its location, the arcuate popliteal ligament, but definitely needle into that lateral collateral ligament. Okay, so the verbiage on lateral collateral. Primary, the lateral collateral. Secondary, slow down. Secondary would be biceps femoris, the IT band, the lateral patellar retinaculum. So it does carry around into this area. So the lateral patellar retinaculum itself. Lastly, vastus lateralis, more anterior, and tibia anterior. Again, a lot of the other things around here could be needle as well, depending on what you're finding is symptomatic and inflamed. Okay. For runner's knee, let's talk a little bit about that. Runner's knee can be a couple of different things. It can be either an IT band syndrome, as the IT band comes across the lateral aspect of the knee to insert into the Gerdy's tubercle, or it can be patellofemoral syndrome. They're often used either way. But what we treat would be different here. Let's talk about it as patellofemoral pain syndrome. Let's look at that here. Actually, we'll call this IT band syndrome for runner's knee. We'll address patellofemoral syndrome in just a moment. So the IT band syndrome, which is when we were dealing with the hip and the low back, we dealt with IT band more where it attached onto the ilium. Here we're dealing with it more right in the knee itself. So here our primary locations are going to be the lateral and the medial patellofemoral ligament. And so with that, we're just going to come lateral off of the patella, about a finger breadth, both lateral and medial, and to needle down into that patellofemoral ligament. The medial patellofemoral ligament, definitely that band of tissue that gets injured whenever we do have that sublux knee, which we'll also talk about in just a moment. Secondary locations, the quad tendon, more proximally, and the patellar ligament distally. And then from a tertiary standpoint, the medial and lateral patellar retinaculum. I don't include that here. If I'm dealing with an IT band issue, I definitely want to go proximal to the tensor fascia lata itself, the muscle origin of this entire band. We're told, research says that we can't really stretch this tendon to get more length out of it. However, if the muscle that it's attached to is under a constant load, say to a low back pain problem, then it can definitely keep that tension on that. So reducing that would be important. So I'd include in here also the IT band or the TFL as well, definitely need to be addressed. If that's normalized, then as we needle into the lateral patellar retinaculum, we will be needling into that IT band as it's crossing to attach here onto Gerdy's tubercle. Our target structures there, we talked about that. So let's see if I was fortunate enough to include this in our 3D anatomy. I'm going to assume no, so let's do this. Okay, so we've got everything there. So here we have the IT band coming across. Again, if I'm dealing with this myself and it's not an actual runner, if it's an older person or more sedentary, then odds are we're dealing with a low back issue that's creating problems running down the leg into the lower leg. So definitely let's needle through the TFL first and reduce that load. As we get further with this runner's knee, the patellar, lateral and medial patellofemoral ligament as they come across and attach. So there's lateral, here's medial. Definitely want to needle that. Adjacent to that and superficial would be the lateral and medial patellar retinaculum. If we needle the lateral retinaculum more towards the posterior aspect or further lateral piece, then we will needle into that iliotibial tract as it's coming down to its insertion into Gerdy's tubercle. Dealing with any issue there, obviously, probably we'll see that we have a quad tendon patellar ligament issue. But the biggest issue, deal with the load in TFL, catch the medial lateral patellofemoral ligament, and then the retinaculum, and then lastly into the distal IT band itself. For shin splints, happens very frequently. I became an advocate of dry needling these after dry needling my wife's chronic shin splints. After running, those things would just get out of control. Needled them 4 or 5 years ago and hasn't had a problem with them since. So for shin splints, primary location, anterior tib, extensor digitorum longus. So predominantly, this is going to be our culprit. Everything that causes that inversion or eversion and dorsiflexion is what we want to hit there. Secondarily, we'll look at peroneus longus and extensor hallucis longus, and then lastly, the bicep femoris tendon and the distal IT band in that area right there. So I'm going to just jump back and cover those here. So for our shin splints, again, first, tibia anterior, extensor digitorum longus. So we'll needle those first. Very common. We may see that it extends further laterally into the peroneus or the fibularis longus, so may want to hit that as well. If that's not the source of our issue, our inflammation, let's come a little bit more proximally. Let's look at the IT band and the tendinous attachment of bicep femoris onto the fibular head. Most commonly, needle tibia anterior, extensor digitorum longus, and that's going to be a remedy for the acute, subacute inflammation associated with the shin splints. Accompany that with some stretching and then some strengthening into that, and that should rectify the shin splint problem. If it's a recurrence after that, then there's probably a mechanical issue related to an arch or internal external rotation of the tibia on the femur. Okay, Osgood-Schlatter. We see this very commonly, and basically considered apophysitis of the tibial tubercle. Usually happens in skeletal immaturity, younger people before that growth plate is sealed. And so we're familiar with that big prominence at the tibial tubercle. So our treatment approach here, we will needle on. So the site of discomfort is in that location right there on the tibial tubercle. So let's drop our first location, needle onto that tibial tubercle, some periosteal pecking to help with that. Secondary, let's come up and let's needle into the patellar ligament and the quad tendon. So the ultimate challenge here is the quad is loaded. It's got a low-grade strain on it at all times, and it is not letting that pull through the quad tendon, through the patellar ligament to its attachment on the tibial tubercle, let it reduce the load and the stress on that. So second, we hit the ligament below, the tendon above, and then finally we catch the quads themselves, right? Fem, vastus lateralis, medialis, and intermedius. So let's come here. Look at there, I have one. So here we are. Yeah, the prominent feature is the pain tenderness and a prominent bump here at the tibial tubercle. So first approach, let's needle onto the tibial tubercle, and then we're just going to move proximally with this. Next, we'll look at our secondary. We'll look at the patellar ligament, the quad tendon, and then we'll deal with what's driving this in the first place, which is well, it's because of the non-closure of the growth plate, but it's the load through the quad, rec fem, vastus intermedius, lateralis, and medialis. Use those same points we've used on there before. Hoffa syndrome. The Hoffa's fat pad sits behind the patellar ligament. Occasionally, it can be inflamed. It can be painful. Occasionally, it can become entrapped between the femur and the tibia. And so a couple of things we'll look at. One is needling for inflammation control. So you see it here. Here's the patella, and it sits behind the patellar ligament, behind the infrapatellar bursa. Primary locations, we're going to go medial and lateral to the patellar ligament. So we're not going to immediately go into that ligament. We want to go on either side and see if we can elicit our response. In the case that we have a patient where Hoffa's fat pad is getting pinched in between the femoral condyles and the tibial plateau, we can take the needle on either side or both sides, put them into that fat pad. We can use our unidirectional rotation and pull that, or attempt to pull fat pad posterior. If we can do that, if we successfully relocate that fat pad, then we may be able to take and eliminate that as a source. We definitely want to continue to look at this as an inflammatory problem. However, as it's inflamed, it gets larger and swells, it will have the tendency to push into that joint space. So second, we'll hit the patellar ligament and the quadricep tendon, and then rec fem, vastus lateralis, vastus intermedius, vastus medialis. So let's take a look at that. Notice there it is. So here we have, I've hidden, then I've turned off basically the ligaments, patellar ligament and the retinaculum on either side. The patellofemoral ligaments are still in place, but it did it this way so that we see the underlying bursa, and then deep to that bursa is office fat pad, just sits in that space. And you can tell if it gets extremely inflamed, it does have the potential to move more posteriorly into that region, which would create even more inflammation of that fat pad. And so first primary location, bring that back up. We'll go to both medial and lateral to the patellar ligament and needle from lateral to away from midline toward midline in a V approach. See if we can see that on my camera. So we'll go at it this direction into that fat pad. Again, if you feel like there may be some compression in between femur and tibia, we can do the unidirectional rotation and then try to retract that tissue anteriorly. After that will come needle into the patellar ligament, into the quad tendon. And as always, we want to decrease that motor that motor load on the quads themselves. For lateral patellar subluxation, this situation, we're assuming this has already taken place. Our primary locations, so what happens here is anytime we see an initial subluxation, we're going to see a strain, if not a complete tear, of the medial patellofemoral ligament. So very first thing we want to do is come in and needle that medial patellofemoral ligament. Anytime where we have that sort of situation, or if that ligament is inflamed, it's very easily palpable, and it's very your subject is definitely going to know that you've hit the right thing. So we'll drop laterally medial patellofemoral ligament and the medial patellar retinaculum. We'll go from there. We'll go ahead and move up and hit the quad, the medialis, rectum, vastus lateralis, and vastus intermedius. And then from a tertiary standpoint, we do want to, in case there is a secondary load, there's a lot of static tension, and then lateral structures that's helping pull that thing laterally. We want to go ahead and hit the lateral patellofemoral ligament, the retinaculum, and then let's go ahead and hit the patellar ligament and the quadricep tendon. So let's take a look there. So again, what we're looking at is initially, let's hit this medial patellofemoral ligament, because that is going to be what's most inflamed, if not torn. So we want to create that inflammatory response there. Go ahead and hit the medial patellar retinaculum. From there, we want to hit the muscles of the quads. After that, assuming that this tissue is starting to shorten and tighten from the lateral aspect, again, lateral patellofemoral ligament, the retinaculum, and then let's go ahead and hit the patellar tendon, patellar ligament, and the quad tendon itself first. But any case of lateral subluxation, first to go to is always these locations right here. VMO, because we want that VMO to help support that medial stabilization, and then the medial patellofemoral ligament, and to a lesser degree, the medial patellofemoral retinaculum. All right. Now, for joint line pain, we'll look at meniscal injury both for the medial and the lateral. So lots of ways to approach this, and every access to the meniscus for each individual patient is different. Our loose pack position is approximately 25 degrees of flexion, depending on the habitus of the knee itself. You may find that even being on a bolster may do better. But in a perfect situation, getting into that loose pack position, For the lateral meniscus, we can go sideline, put a pillow between the knees, and place the knee at 25 degrees flexion. That'll make it very simple for us to palpate and locate whether that. So the palpation part is important to determine if that's an anterior horn or a posterior horn tear or pain in that meniscus. It could be maybe you have it in both. Usually you'll find one or the other. But you can definitely needle in between the joint line between the femur and the tibia in this loose pack position into that ligament, that meniscal tissue. Similar. So that's our primary anterior posterior meniscus. For secondary, would look at lateral collateral ligament, the bicep femoris, IT band, popliteus. So anything that's around that, if the ligament, if the meniscus is inflamed, if there's some tear, the structures around there will be involved. So we want to identify those so that we can needle those. Tertiary, always we're going to go hit the quads because that's driving everything at the knee. For the medial meniscus, here let's again we'll go supine here. The knees at 25 degrees flexion. Again, that loose pack position, roll under the knees. Again, here we'll look at anterior, posterior meniscus. After that, we'll look at the MCL. Again, here are the pes, they're hidden. The pes tendons coming down, the pes bursa. And then the semimembranosus tendon as it's coming down right through there. Lastly, rec fem and the quad grouping itself. So let's look at that on approach. Yes, I do needle the meniscus frequently. Yes, we do get a good response from it. When we look at the available research on the outcomes of knee arthroscopy, the evidence just really isn't there to support that it's a great outcome, other than as compared to exercise or other treatment approaches. I'm eager to see more people evaluate and look at meniscal dry needling. I know that we have seen some really good results with that. Again, looking at the medial meniscus, definitely we want to just get into that meniscus itself. Again, 25 degrees is ideal for our loose pack position, which makes it, if this meniscus is extremely flattened and short, then that space between the femur and the tibia is going to be significantly reduced. So that being said, we definitely want to make sure that we give us our best chance at getting better penetration into the meniscus itself. The pes bursa, the pes tendons, and then semimembranosus tendon itself as it comes down. If we look at the lateral meniscus, okay, very similar. We're going to get in that loose pack position, about 25 degrees of flexion, so that we can get into that. Here, in addition to that meniscus, either anterior, posterior, wherever we're feeling, assessing where that pain and inflammation is, we'll needle there. So we'll go ahead and needle the lateral collateral ligament, bicep femoris tendon, and then here comes the IT band coming down, attached at Gertie's tubercle there. Medial meniscus, more common of an issue, simply because of its attachment to the medial collateral ligament. More common to see that on the medial side, but we do frequently see good results when we do have lateral meniscal damage as well. All right. For chondromalacia patella, these get a little bit more challenging from a technical standpoint. And the reason for that simply is the very small space between the patella and the femur itself. So again, we want that loose pack position at about 20-25 degrees where we have our easiest access under here. That'll give us freedom to see or gain access to superior aspect of the femoral groove and to the undersurface of the patella as well. So here our primary locations are going to be the lateral patellofemoral junction, both superior and inferior, and then the lateral patellofemoral ligament. More often than not, we're going to see that issue on the lateral aspect. After that, we can move to the medial patellofemoral junction, superior and inferior. And our whole goal is just to penetrate into this space, hopefully onto that hyaline cartilage on the undersurface of the patella primarily, but hopefully maybe even onto the femoral junction as well. Again, as with everything, we want to also make sure we include the muscles of the quads. All right, so last piece here. Okay, sorry, my brain turned off momentarily. Here we are. Okay. So again, for chondromalacia patella, first thing we want to do is, again, more often than not, it's going to be lateral. And so we're going to put this person in 25 degrees of flexion, and we're going to try to get in between the patella and the femoral condyle. Our ultimate goal would be to land, again, on that hyaline cartilage on the undersurface of the patella, both inferior and superior on that aspect at that lateral pole. We know that we're going to have an issue with the medial and lateral patellofemoral ligaments, so we'll needle those as well. But let's start laterally, and then let's move medially. Medially, you may, so in either direction, you may find that you have to take your finger and relocate that patella to a medial aspect and let it tilt up so that you can needle underneath to that undersurface. Or if it's lateral, you may have to advance it even further laterally to needle underneath that surface. And so anyway, we needle underneath the patella, trying to hit that hyaline surface there, the medial and lateral patellofemoral ligaments, and then lastly, the muscles of the quadriceps themselves. Okay, so that was a lot of content. There's a whole lot to happen in the knee. Again, we do see a lot of duplication when we talk about the knee. So let's move now to our post-lecture assignment. Very similar, matter of fact, the same assignment that we saw from the hip. Want to submit a sample 3D kinetic screen of participant, subject, friend, I don't care who it is. But let's look at all the pieces of that, and let's pay particular attention to the trunk on down specifically, because we'll see that reflected in what's happening at the knee. I want you to submit a brief description of what your analysis is of the 3KS, and with a focus on the trunk and lower body, and then with what you're seeing, using your own judgment, what muscles, tendons, nerves, protocols, what would you recommend for potential dry needling based on what you're analyzing as an issue there. So up next for this cohort, it's going to be November 1st of this year. If you're asynchronously, it's whenever you hit the button again. Up next is advanced dry needling of the ankle and foot. There is a lot of content in this. In the future, I may consider breaking this into 2 different lectures, but we have 3-week break until we get to this. And so that's upcoming. In the meantime, you have your homework. If you have questions, issues, just yell at me, let me know what they are. And I look forward to seeing each of you on our next lecture, ankle and foot. We've got one more after that for the pelvic floor, and then we have completed all 16 lectures at this point. So 14 down, 2 to go.